Okay, we'll go ahead and get started. For those of you that don't know me, my name is Derek Leffert. I'm the managing principal of the 109 Group, and we serve as your lobbying firm in Jefferson City. In addition to that, we manage the association, and I know I've interacted with a lot of you fairly regularly, either in person or via email or phone, so we appreciate everybody being here, and we are proud to represent AMNP in both capacities. So I'll take the first half of this presentation, and then Lila Pennington, who is our senior policy analyst, will cover the second half of it. She's going to go through the AIM bill, and then we'll break after that, and well, not break, but we'll move into another presentation after that. Just a quick programming change. Our speaker on pancreatitis was hospitalized, and so he will not be here tomorrow. Or I'm sorry, he won't be here this afternoon. So as a result of that, we're going to switch. So the presentation that I was going to do tomorrow on APRN advocacy is now going to be moved into that spot, and then we'll move everything else up if we can do that with the speakers, tomorrow afternoon speakers. So we'll get, good news is we'll get done early, and I'm sure that's probably not going to be an issue for a lot of folks here. So give me more time to get out and enjoy the lake. So really kind of the focus of this presentation here is to talk a little bit about what happened in the 2020 legislative session. I'm sure most of you guys can guess that it was not a normal legislative session, and I guess no session really is at this point, but it was certainly not a normal session, and we'll talk about why it wasn't normal over the course of the presentation. So really what we're going to do is we're going to cover just general information, what some of the challenges were that we faced, what passed, what didn't pass. We'll go over the bills that were specific to APRNs, and then we'll talk about some of the bills that were actually passed and signed by Governor Parson. So for those of you that are either here in person or participating online, you're welcome to ask questions, but since we're using this format, then we're going to go ahead and move forward, and then we'll ask questions as soon as I'm done before we turn it over to Lila for her section. So how many of you guys participated in any of our advocacy days that we have done in the past? I know I've seen several of you there. We appreciate you guys coming to Jefferson City. We had 2 of those slated for this year. Unfortunately, they stopped allowing visitors at the Capitol for the time that our second one was slated for. So we only got the first one in. We did that in February. We had a pretty good attendance. We had pretty good visits with individuals throughout the Capitol. I think most of the people that participated found that the message was well received. There's probably going to be a few legislators that generally are going to be kind of standoffish towards MPs, specifically those that are physicians in the legislature, those that sympathize with those. But by and large, I think the message was pretty well received. And again, we did that in February. I think we had about 50 folks there advocating from a grassroots level for MPs. So it was great to see that many folks there. We did initiate a call to action this year prior to spring break, prior to the COVID situation happening. How many of you guys remember sending out an email asking you to engage with your elected officials about the definition of surgery and not allowing MPs to use the term doctor? So that got people fired up. That we had a ton of people fired up about that. I think that's probably the most engagement that we have ever had when we have initiated a call to action. So that's the sort of stuff that happens in the Capitol, and that's why you guys need representation there, and that's also why you guys as MPs need to engage whenever we send out. We do our best not to send out repetitive calls for action because we don't want to bore you, and we don't want you to get used to it and get complacent. So when we send those out, when we ask you to engage with your elected officials, we absolutely need you to do it. So we did that, and had very good results with that. On 942, we were able to kill that bill, and that bill didn't move forward out of committee, despite that bill being the committee chair's bill. We've also asked you guys to engage with testimony. whether that's written testimony or testifying in person. I know Tammy testified in person. Joanna's testified in person. Lila's testified in person. There's a lot of folks that have, and that's very, very important because that kind of puts a face to the issue, and we love to see our folks there testifying on behalf of NPs in the profession. So that was kind of what happened this year as far as our advocacy engagement. As far as general session information, there was over 1,500 bills filed in the House. Only a few of those were finally passed. Of the 34 bills that were passed, I think 20 of those were budget bills. So the House only had about 14 bills that were non-budget bills that were passed. We'll go over that more here in just a bit. Senate filed considerably less bills. There's 34 senators versus 163 representatives. There was 13 of their bills that got passed, and then they had 2,500 plus amendments and floor substitute. That number, the amendments, the floor substitutes, and the committee substitutes, that number is typically higher on a normal year, but because there wasn't as much activity this year, there wasn't as much, there weren't as many amendments. So, okay, I lied earlier. I said 20. There's 29 non-budget bills that were passed, and of those 29, 9 of those 29 had language in that in some way, shape, or form had an impact on APRN. So whether it was a healthcare related bill, whether it dealt with Medicaid and Medicare, whether it had an APRN provision in there directly, in some way, shape, or form, 9 of the 29 bills that were passed affected you guys in some way, shape, or form. We tracked over 100 bills for AMNP. And I will tell you, just to give you a comparison here, so we manage 5 different associations, and we also have several other organizations that we lobby on behalf of. Typically, those organizations are tracking anywhere from 10 to 12 bills on any given year, but healthcare, anytime you touch the healthcare spectrum, there's going to be a significant number of healthcare bills that are out there. So we were tracking over 100 of those. You can see the ones that had an impact on APRN, Senate Bill 551, 569, 591, and the remainder of the House bills there. House Bill 1682, which we'll talk about in a little bit, was a general omnibus healthcare bill that got a bunch of stuff crammed into it. And then House Bill 2046 had some licensing provisions in there that became a licensing omnibus bill as well. As far as what the makeup looks like of the House and the Senate, there's 163 representatives. There's 2 vacancies right now, 113 Republicans, 48 Democrats. And then on the Senate side, there's 23 Republicans and 8 Democrats. And then there was 3 vacancies. I will tell you that Republicans do have a super majority. So they have a veto-proof majority in both the House and the Senate. So really the issue that the Republicans have right now in the Capitol is they fight amongst themselves, among their own caucus. So that's kind of the makeup of the General Assembly at this point. That could potentially change. In case you didn't know, it's an election year. I'm sure people are probably ready for that to be over with. And I share that same sentiment. It probably won't change dramatically. The makeup of the House or Senate won't change dramatically, but it's possible that it will change a little bit. Missouri is a very red state. For a while, it was kind of a purple state, but it is very, very red. There's only one statewide office holder that is a Democrat, and obviously the House and the Senate have far less Democrats than Republicans, and those Democrats are primarily concentrated in the urban areas. So what are some of the things that we saw happen? What challenged us in our agenda in the 2020 legislative session? Can anybody guess what the #1 challenge was? Same challenge that you guys had, right? COVID-19, it is unheard of for the Missouri General Assembly to cancel or postpone session. And I've been doing this 18 years. I've been lobbying for 18 years. And we have had terrible weather. We've had ice storms. We've had a number of different things happen. And never in the history that I'm aware of, outside of, during the Civil War, has anything been canceled in the General Assembly. I will tell you, so the way the legislative session works, they come in first part of January and they leave in mid-May. So you have anywhere from 16 to 19 weeks to get some things done. That may sound like an awful lot of time, but it really isn't, because the legislature works Monday afternoon, Tuesday and Wednesday all day, and half a day on Thursday. And so there's a lot that goes into that 18, 19 weeks. And when you take 6 of those 18 weeks out of the fold, then you can imagine how challenging things become. So what that led to this year was that led to, well, let me back up for a second. Typically what happens is towards the end of session, every bill becomes what we call a Christmas tree, and everybody's got an ornament they want to hang on that Christmas tree, right? So it's an amendment, right? If you've got an amendment, we call that an ornament, and then the Christmas tree is the omnibus bill. This year, that happened more so than you can even imagine, because there were fewer bills moving, there were fewer opportunities for stuff to get done, and so every bill became a big omnibus bill. The omnibus bill that we specifically need to focus on, we'll talk about in a second, is House Bill 1682. So COVID was our biggest challenge this year, and it wasn't just us. Obviously, everybody had that same issue. A couple other issues here were some senators and then our opposition. So you can see there 3 pictures of some individuals that are not friends of MPs in Missouri. So there's Dr. Bob Onder, who's a senator out of the St. Charles area, Senator Jeannie Riddle out of the Callaway County area, and Senator Bill White out of the Joplin area, that his wife is a neurosurgeon. So those individuals, especially when you have an enemy in the Senate, they can gum up the works for you. They can threaten to filibuster. They can use their position to try to leverage action on other items. And so those individuals, particularly Senator Riddle, Senator Onder and Senator White weren't so much an issue this session as Senator Riddle was. Senator Riddle chairs the Professional Registration Committee in the Senate, and Senator Riddle can either help us or hurt us depending on what she does in committee. And that Senate Bill 942 that I mentioned earlier, that was basically telling us that we or you as MPs wouldn't be able to use doctor, and you wouldn't be able to perform the routine surgery things in your clinics. That was filed by her, and the reason that she filed it is because there was an expectation that she was going to get that out of committee because it's her committee. We were able to successfully defeat that and keep it from ever coming to a vote. She had planned to vote on that up until about 30 minutes prior to the committee vote actually taking place, and then I saw her chief of staff, and she said, "We're not going to vote on that this week," which meant we don't have the votes. Is exactly what it meant. So we were able to successfully kill that particular bill. But they were obstacles. Obviously, your physician groups, Missouri State Medical Association, osteopathic physicians and surgeons, the family practice physicians are significantly opposed to anything that we're trying to do. They're not willing to give an inch on anything. So they're always going to be a significant obstacle. But I will tell you that the longer they continue to spew their continuous, regurgitate their talking points, the more tired elected officials become of those. So that's kind of where things were at as far as our challenges. Taking a look at just generally what passed and what didn't. License reciprocity passed. So for those of you, I know Peter's in the military, there may be a couple others of you that are in the military, or your spouse may be in the military. The license reciprocity bill was a big thing for Governor Parson. And basically what that was allowed people that moved in here from other states to immediately get a license based on whether you're a nurse or whether you were an engineer or however you were licensed. There was some steps made to try to reduce some of the barriers and give you a license immediately so that you could begin practicing your trade here in Missouri. Much to many people's chagrin, the motorcycle helmet law was repealed. That went into effect on August 28th, and I will tell you that I have seen an awful lot of people out there riding around without their motorcycle helmets on. So you may see that, especially if you're in the ER, you may see that issue. I'm ride a motorcycle myself, and I would never, ever get on there without a helmet. But to each their own, but that was passed in August 28th, it took effect. Hyperloop I'm sure some of you have heard about basically a super fast train from Kansas City to St. Louis. That is a monstrously expensive proposition, and there was a task force basically created. There was no money allocated for it, but that is a very, very popular thing with Governor Parson, and basically his campaign manager. That's a big thing for him too. Punitive damages, that could potentially touch you guys as NPs. How many of you guys in the room have ever been sued? Anybody? For your practice? It does happen, can happen. That's why you have malpractice insurance. But there were some caps placed on the amount of damages that could be awarded for punitive damages in any particular situation. So that could potentially impact you. Forensic rape testing was a big issue. Cleaner Missouri, that was a huge priority of the Republican caucus. So if you guys recall, back in the last election year, there was an amendment passed that said lobbyists couldn't provide gifts to elected officials. That was really kind of the devil's in the details on that. That wasn't what that bill was all about, or what that amendment was all about. What it was about was the underlying issue of the state demographer redrawing legislative districts. So the Missouri General Assembly passed a fix for that. You'll see that on your ballot in November, basically that tries to correct that issue. I mentioned it earlier, this healthcare omnibus bill as well. What didn't pass? We're going to talk about the AIM bill here in just a second. AIM bill is one of our priority bills, or is our primary priority bill. That was authored by a number of different MPs. Lila's going to talk about that. She helped write that. That is a significant bill and a significant step forward for MPs in Missouri. That essentially creates a period of time where you would practice as an MP, a new MP, and then after you had completed that time, then you would then become an independent practitioner, if you so choose. The barrier reductions bill did not pass. The APRN licensure bill did not pass. There was another bill that was filed that would have been pretty disastrous for APRNs. Senator Onder filed a bill to require the Board of Healing Arts to regulate APRNs rather than the Board of Nursing. As you can imagine, the Board of Healing Arts would probably not be inclined to give APRNs favorable treatment, and so we were able to kill that. PDMP. How many of you guys know that Missouri is the only state in the nation that doesn't have a PDMP? That particular bill was this close to the finish line. I mean, it almost made it across the threshold, but there were some procedural things that happened in the back end that really created some problems for that. So that didn't pass. It was as close as it's ever been, and I suspect that you will see that resurface. So the House handler of that, how many of you guys have heard of Representative Holly Rader? She's the one that has carried that over and over again, and it's a huge passion of hers. If she is successful in her Senate election down in the boot, is anybody here from the Cape area, southeast Missouri area? So if you're down there, Holly's running for the Senate down there. If she's successful with that, you can expect to see her, that'd be her top priority in the Senate. So that's going to be a little bit different next year. Wayfair, sports betting, that stuff didn't pass either. So let's take a look at the various different APRN bills and kind of what their status was. House Bill 1441 created an APRN license. House Bill 1617 removed the mileage proximity on APRNs working in alternatives to abortion agencies. 1816 removed geographic proximity for any APRN working in a second, third, or fourth class county. So if you were in St. Louis County, Jackson County, Boone County, Greene County, you would still be subject to that mileage restriction, but not if you were outside of those types of counties. House Bill 2226 was a barrier reduction bill. 2382 was the companion bill to Senate Bill 942. House Bill 2583 was basically an AIM bill, the House version of the AIM bill. Senate Bill 714 was an APRN licensure bill. 863 was a CRNA bill. 932, which we would have supported, basically prohibited a non-compete agreement between APRNs and physicians and hospital or health systems, nonprofit health systems. Senate Bill 942, we already talked about that. Senate Bill 965 is the primary AIM bill that was authored, and that's what Lila's going to cover here in just a second. And then Senate Bill 1078 was an APRN licensure bill as well. So all of those bills didn't pass. We had pretty good traction on Senate Bill 714, and we were moving along with that until COVID hit, and that kind of blunted any momentum that we had. So of the bills that were passed, of the 29 bills that were passed that had an impact on APRN in some way, shape, or form, these are the ones. And I've got copies of the truly agreed summaries out there if you'd like to see those. Those are also emailed out to our members as well. So Senate Bill 551 had organ donation, insurance coverage, medical malpractice in it. 569 had telehealth for sexual assault victims. Basically, that was a sexual assault bill that was passed. Punitive damages for medical malpractice was in 591. I mentioned that earlier. Electronic. How many of you guys are working in long-term care? Anybody here working long-term care? So there's electronic monitoring that was passed that now allows electronic monitoring in nursing homes. 1511, House Bill 1511 was basically the military spouses don't have to jump through a bunch of hoops to get a license. They can now go ahead and get a license fairly easily. 1682 was really the biggest healthcare omnibus bill. As you can see, there's a ton of things in there. And this is what happens at the end of session when people start cramming stuff into bills. So I'll go through those. Health awareness designation, AED access, physician assistance on ambulances, DNR orders, medical marijuana telehealth, administration of controlled substances, epinephrine auto-injectors, causes of action on opioid, remote dispensing pharmacies, healthcare claims reimbursement, pharmacy benefits manager, breast cancer screening insurance, life care contracts, healthcare claims overpayments, healthcare practitioner credentialing, confidentiality of health records, COVID-19 testing, and DSS program waiver. All of that was crammed into a single bill that was passed in the last week of session. So you can imagine that a lot of these bills grow to hundreds and hundreds of pages, and you can imagine how complicated that gets. House Bill 1896 was also passed that prohibited the state from releasing information for medical marijuana licensees. 2046 we talked about, and then House Bill 2456 was a sunset extension on managed care. So that is a very, very quick review of what happened with the legislative session in 2020, and a lot of that stuff is going to carry over into 2021. So as far as the agenda, the board had a discussion, the AMNP board had a discussion last night about the legislative agenda for 2021. Obviously, we're going to continue to improve on that, the access improvement for Missourians. We're going to pursue that again. We'll go ahead and pursue barrier reductions again. How many of you guys saw where the governor suspended some of the rules back in March due to COVID? We sent out a significant amount of updates on that, and we were actively and I would say aggressively lobbying the governor's office. I think Jeff Earl probably got tired of me calling him and saying, hey, what's the deal on this stuff? When are you guys going to move on it? But we aggressively pursued some suspension of those rules, and we were able to secure several of those with our other partners. Mona partnered with us as well, and other APRN groups. So the rules that were suspended by the governor was the mileage restriction, the 30-day practice period for you when you're with a new collaborating physician, chart reviews. There was a home health. Now you as an NP are able to order home health. And then there was a hospice provision in there that allowed NPs to serve as the attending provider on hospice patients. So those things were done via executive order. That was tentatively in the initial stage, that was passed until I want to say May 15th, and then it was extended from May 15th to June or July 15th, and then it was again extended to the end of the year. So all of those rules that were suspended are suspended until December 30th of this year. We are going to pursue a continued suspension of those, as well as when the legislative session begins, we will pursue a permanent revocation of those in the 2021 legislative session. An APRN compact, that's something that a couple of states have right now. An APRN compact basically establishes a license for people that are going to be traveling between multiple states or want to work in multiple states, much like an RN compact works. So you would have basically licensure in states that participated in that. That's something that we may pursue, an APRN license. That's not something that we specifically are taking the lead on, but we support NCSBN in their efforts for that. Hospice attending, as I mentioned, in the home health, that is going to be something that we pursue as well. One of the biggest things that we can do for you in the Capitol is, obviously, we're trying to push and be offensive with how we pursue things on your behalf, but probably one of the biggest benefits of having someone in the Capitol working on your behalf is being there to guard against things that are going to be harmful to you or your profession or your patients. So defending against the Board of Healing Arts oversight of APRNs, anything that would materially impact how you practice or how anything that would affect your practice at all is what we're there to defend. I can tell you a quick story here of, I was sitting in a committee hearing one time. They were looking to generate some new revenue, and the people at the table, the elected officials that were at the table, were trying to figure out who they could tax or what they could tax in order to fulfill this program need. And so I saw them specifically look around at each other and say, who doesn't have representation in the Capitol? Who doesn't have a lobbyist here working on their behalf? And they figured out, they were like, hey, dry cleaners don't have a lobbyist up here. Let's impose a tax on dry cleaners. So they did. That was a perfect example and reflection for me of why it's necessary for all interest groups to be represented in the Capitol. So keep that in mind. It's not so much what we do offensively, but also what we do defensively on your behalf as well. I will tell you that if that Senate Bill 942 would have passed in its form that it was in, there would have been a lot of you that your practice would have been significantly impacted. You wouldn't be able to do suturing. You wouldn't be able to do biopsies. There's a number of different things that you guys wouldn't have been able to do. So having people there representing you is very, very important. As far as the makeup of the General Assembly next year, there's going to be 46 new House members and 11 new senators. And the reason I say they're going to be new is because those individuals are termed out, so there will be someone to come in to take their place. Right now, there's 32 Republican seats, 14 Democrat seats in the House, and then 6 Republican seats and 5 Democrat seats in the Senate. There is a potential for the Senate to flip. Anybody here from the St. Louis area? Senate District 15 is currently represented by Senator Koenig, Andrew Koenig. He's in a fairly tight race against Deb Lavender over in that Senate district. So there's a possibility for that particular seat to flip, but overall, the makeup is not really going to change significantly where all of a sudden Democrats would be in control and Republicans would. That's just not realistic at this point. So as far as the dynamics next year, obviously coronavirus is going to change the dynamic. Frankly, that's going to change the dynamic for us for the better, because I believe, as in the conversations that I've had with elected officials, they have seen the importance of healthcare providers and providing access to healthcare, and that benefits us. That works in our favor. So I am confident that the dynamic of the conversations is going to be different next year, and I hope that to the extent that we can utilize the coronavirus for our purposes, we certainly intend to do that. And I know that sounds very opportunistic, but it is what it is, and if we can use that to further our goals, then we certainly will. Post-election atmosphere. Who knows what's going to happen, right? At the federal level, at the state level, who knows what's going to happen? And that could potentially play into how things go in 2021 legislative session. Not so much on the state level as on the federal level. PQ hangover. So how many of you guys have heard of previous question, the Senate using the previous question? So it's a procedural move, and the Senate very, very rarely uses that. And when they use that, typically that is viewed as the majority dropping a bomb on the process, right? They don't use it because it makes an awful lot of people upset. The Republicans in the Senate did that in this last special session on a crime bill. They did it in this past legislative session, and as a result of that, you can expect that there's going to be some hell to pay when things resume in January. So there's going to be a little bit of a hangover there. There will be new leadership, especially in the House. Elijah Hart has turned out, so Rob Vescovo will be taking his place as the Speaker, and as a result of that, there's going to be more people moving up the ranks in the House. Senate leadership won't change much, but House leadership would. There could be a potential shift in the statewide offices. So Mike Parson is running against Nicole Galloway. There's a possibility that Galloway could win that, and then we would have a little bit of a shift there. So I know I went a little longer than I intended to, but does anybody that's here have questions for me before I turn it over to Lila? I know I covered an awful lot of ground there very, very quickly, so I apologize if I lost you here. So we will be doing the APRN advocacy presentation here this afternoon. So that's going to shift to the, I think it's 1:30. Is that what it says, Tammy? So we'll do that, the APRN advocacy at 1:30. Yes, ma'am. So the question for the virtual attendees, what's the plan for the things that have been essentially suspended during COVID? What's the plan if that goes back? We're going to continue to aggressively lobby the governor's office to continue to suspend those. I don't believe that the coronavirus is going to go away in December. So I suspect that he would be receptive to extending those rule suspensions. I talked to Jeff not last week, but the week before, and he seemed to think that he would be receptive to that, but there's been no guarantees on that. So that's why it's important for us to pursue that permanent revocation of those rules, and that's what we'll do in the 2021 legislative session. But he can continue that executive order as long as we're under a declared state of emergency. So as to your answer, what happens when and if we go backwards, I don't really know. All I can say is we're going to continue to aggressively pursue efforts to permanently revoke this. Other questions? Okay, I'm going to turn it over to Lila real quick. Here's my contact information. If anybody needs it, maybe. That's my cell phone number. Most of you have the email address for the association and the office number for the association. You'll get Andrea that's sitting out front there. So I'm going to turn it over to Lila, and she's going to cover the AIM bill in the 20 minutes that we have left.
We talked about the AIM bill. AIM is an acronym for Access Improvement for Missourians. We decided to call it that instead of a transition to practice bill. That gets real confusing for legislators and things. And that we wanted to focus also on the fact that that we're not to focus on ourselves, but to focus on the things we can do for our patients if we are allowed to practice without a collaborative practice agreement. Now, being allowed to practice without a collaborative practice agreement does not mean that all of you will have to practice independently, nor does it mean that you all have to go out and open your own clinics. Most of you will stay in the same positions and same jobs that you're currently in. Your organization may require a collaborative practice agreement, but we are trying to make it, if you are required by your organization to be under collaborative practice, to make that collaborative practice much less. And this, by allowing nurse practitioners to practice without a collaborative practice agreement, we know that's safe according to the research, and we know that will expand access to care, especially in rural areas and also in underserved urban areas. Okay. All right, so the AIM bill, the reason I wanted to explain this to you is because it is very long, and we had two Republican legislators who introduced it, one in the House, Mike Stevens, and one in the Senate, Cindy O'Laughlin. And Cindy O'Laughlin read through it and was fine with it, but some legislators had a little trouble because it was they thought it was so complicated. The number one reason that this is such a complicated and long bill, and I've got it drawn up on my iPad, the bill itself drawn up on my iPad. It's on my iPad, the PDF is 41 pages long. And there's a reason for that, because every time APRNs got added to something to allow us to do something, collaborative practice agreement was written into that. So collaborative practice agreement is no longer just in the Board of Healing Arts and the Medical Practice Act. It is also in all of these bills. So this is just a little summary of what we did. And you'll see a number there. That is the bill chapter, or the law chapter in the Missouri law, and you can look these statutes up yourself to see what they are. The first one is the Emergency Services Community Paramedic statute. We were in there, we were allowed to give a health care plan to a community paramedic, but we had to have a collaborative practice arrangement to do that. And so we removed the requirement for a collaborative practice arrangement to be able to do that. 193.015 is vital statistics. This was what gave us the ability to sign death certificates, and in this definition of APRN, it said that we had to be under a collaborative practice agreement with a physician. We went in there and removed the requirement for a collaborative practice agreement. All right, so then we went into the drug regulations, 195.070. So in that area, we were restricted in what controlled substances we could prescribe. So we went into that and rewrote that. And I was instrumental in helping to write this bill. I also had a lot of help from the state people at the National AMNP, and they helped me find all the areas in law that we needed to cover. So we're now allowing in this drug regulations an APRN to write prescriptions for controlled substances 2 through 5. And, you know, one of the things that you can do with this information is to explain to your legislators, why do we need this? Because we have to treat patients with severe pain from broken bones, physical trauma, severe documented chronic pain that's not relieved by other medications or treatments, patients on hospice care, pediatric patients with ADHD, patients seeking care for substance abuse. And there are many valid reasons to use controlled substances. And we know that APRNs are not more likely to misuse controlled substances than physicians. We actually do a little better in that area. 195.100 drug regulations continued. We removed the requirement for the collaborating physician's name to be on the controlled substance prescription written by an APRN, because if we don't have a collaborative practice agreement, we certainly can't have their name on a prescription. Okay, then Chapter 208.152, this is Missouri HealthNet. This is a very long piece. So just to make it easy, we went in every place that physician was written, that a physician could provide care for a Medicaid patient. We put physician or APRN. And if it was, and we removed any reference to collaborative practice agreement. We also changed the language in several areas from physician or medically to physician or APRN. And this would allow Missouri HealthNet patients to have a choice of patient care provider. It would be their choice if they decided to have their primary provider as an APRN or a physician. And we do know that APRNs provide a lot of care to Medicaid patients in the state. We, of course, had to go into Chapter 334, which is the Medical Practice Act. And we had to go in there, and it defines which APRNs do not need a CPA by referencing back to Chapter 335, which is the Nurse Practice Act. So we put in the Nursing Practice Act who needed a collaborative practice agreement and who didn't. And so we defined APRNs referring back to that act. And it removes certain acts that require physician delegation through a CPA. In other words, we don't, if this bill passed, we would not need physicians to delegate to us, not only writing prescriptions, but we would need them to delegate diagnosis or treatment. It removes CPA requirements that pose unnecessary barriers to RNs. Let me move this down. I'm having trouble reading my own slides because of this. Okay, there we go. Okay. It removes CPA requirements that pose unnecessary barriers to APRNs in providing patient care. And this removes healthcare improves healthcare access, reduces health cost. Basically, we went into the Chapter 334 and all those areas in the collaborative practice agreement that provided barriers to our practice. We removed all of that so that even if you are required by the Nursing Practice Act to have a CPA, it would limit severely what you needed, what had to be put in that CPA. We removed all the barriers like chart review, distance limitations, chart review, working with the physician 30 days, all of that we just took out. Okay. Trying to hurry up so I can get done here in a minute. We also limited the joint rulemaking authority on collaborative practice arrangements to rules on prescription of controlled substances. So those nurses that need a collaborative practice agreement, and you'll see in the future, those are only nurses with 6 months experience or less. The rules that the Board of Nursing and Board of Healing Arts can make are only on prescription of controlled substances for those nurses, those particular APRNs, not on anything else. We also made null and void all the current rules on collaborative practice. A lot of our restrictions are not only in the law, but in the rules. And because these rules would conflict with the changes this bill would make. And we required that the Board of Healing Arts make available to the public which physicians have collaborative practice arrangements and those persons with whom the physician has them. And so would have to not only let the public know about any APRNs they had a collaborative practice arrangement in, but all PAs and assistant physicians. We changed the wording of collaborative practice agreement to collaborative practice arrangement in order to be consistent with previous language. We removed a requirement to have a collaborative practice agreement, arrangement, which makes that language consistent. And we removed the requirement for in 334.036, that's another area of the Medical Practice Act. We removed the requirement for a collaborative practice agreement. Now let's go into the Nurse Practice Act, where we made a lot of changes. We simplified the definition of an APRN and basically said that an APRN was licensed by, who was deemed as licensed by the Board of Nursing as an APRN. We added a definition for collaborative practice arrangement, which requires APRNs with less than 6 months of practice experience to have a collaborative practice arrangement. That's something we would be willing to think about negotiating the length of time there. We wouldn't want to go past 2 years. I prefer not to go past 1 year, but we started out at 6 months, and that was what AANP suggested, was to start out at 6 months. It adds a definition of advanced practice nursing. We already have in the Nursing Practice Act definitions of what RNs are and what LPNs are and what they can do. So we don't have that for advanced practice nurses. So in there, we put a definition that allowed certain things to be done by an advanced practice nurse with or without compensation or personal profit. One is conducting an advanced assessment beyond that of a registered nurse's assessment, ordering and interpreting diagnostic procedures, establishing primary and differential diagnoses, prescribing, ordering, and dispensing and furnishing therapeutic measures. Oops, hold on just a second. I'm switching back to my iPad here. Okay. Diagnose, prescribe, and institute therapy or referrals to patients to healthcare agencies, healthcare providers, and community resources. Prescribe, order, procure, administer, dispense, and furnish pharmacologic agents, including over-the-counter drugs, legend drugs, and controlled substances. The controlled substances is to an APRN who has a certificate of controlled substance prescriptive authority, which would be issued by the Board of Nursing. So legend drugs are any drugs that are not under the Controlled Act. And we could prescribe any of those without this, but with controlled substances, we would need the certificate of controlled substance prescriptive authority. It would allow us to prescribe, order, procure, administer, and dispense controlled substances on schedules 2 through 5 with no restrictions. Plan and initiate therapeutic regimen, which includes ordering and prescribing non-pharmacologic interventions, including but not limited to home health care, hospice, and physical and occupational therapy. We can already order physical therapy without a collaborative practice agreement, but we just included it in there for completion. Delegating or assigning the therapeutic measures to assistive personnel. And then it talks about that advanced practice nurses will be nurses at the graduate level of education, and they'll be the 4 categories are clinical nurse specialist, nurse midwife, nurse practitioner, and certified registered nurse anesthetist. Okay, so, and then it goes on to just further talk about our prescriptive authority, and all we have to do to get a certificate of controlled substances is submit proof of successful completion of advanced practice pharmacology course, including instruction in prescribing prescription of drugs, medicines, and therapeutic devices. We no longer have to worry about, this would make it so we didn't have to have preceptorial experiences. Most pharmacology courses aren't under a preceptor. Okay, that we do have a APRN license in there, and it defines the qualifications for an APRN license, the license fee, and hearings on if there's a denial of an APRN license. It requires that an APRN with less than 6 months practice experience be in a collaborative practice arrangement, and defines with whom this RN may collaborate, and which may be delegated through a CPA. One of the things we put in there, which I'm sure is going to would get objection, is that we put in there that that new APRN can collaborate with either a physician or another APRN, one who is not required to have a collaborative practice agreement, one who meets the qualifications of over 6 months of practice experience. We think that APRNs are the best providers of experience to other APRNs. It gives the Board of Nursing rulemaking experience on the new license. And does some other things there. It also provides that an APRN's RN and APRN licenses will come due for renewal at the same time, and describes what happens if a license is not renewed prior to expiration. So so we won't have two separate times, one for our RN license, one for our APRN license. We still have to keep an RN license as well as APRN. It describes the titles that can be used by APRNs. Describes who may not practice advanced practice nursing in the state. Okay. And one of the other things that it does in there that I didn't say was that the APRN license, there's a whole application process, but for anybody who currently has a certificate of recognition from the Board of Nursing, you would automatically receive an APRN license. You would not have to go through the whole application period. You would be deemed already and have an APRN license. Finally, we had to go into 338, pharmacist and pharmacy law, and remove the requirement of an APRN to have a CPA. And also allows the pharmacist to fill a prescription of an APRN who does not have a CPA. And then the last one we did was had to go into the Department of Mental Health law, and that's in the part where it addresses APRNs being able to prescribe restraints for mental health patients. We had to go in and remove the requirement for a collaborative practice agreement there also. Are there any questions?